Well, I really like where I am in the order of events because there's so much that's been said that is really resonant with me, to me. And just to follow up on what Dr. Abel and what Dr. Wheelis were talking about, we're not talking about either or here with any of these therapies. We're talking about ends and understanding how to put these all together in ways that make sense is part of what we need to do. I'm going to start with a little anecdote. So I used to be at Columbia. I'm now back at Stanford, and I also serve as chief medical officer at NeuroPace. And one of the NYU physicians who's participating in the study I'm going to discuss told me that he was meeting with a family who was interested in participating in this study. And they said, yes, and we had a neurologist at Columbia 20 years ago who told us that she was leaving because she was going to go to work on something that could help our son someday. So I thought, boy, it's not often that your world starts to circle. But I'm going to talk to you today about a study that is funded by National Institutes of Health through the Brain Initiative, and also supported by the company I'm involved with, NeuroPace, to study thalamocortical responsive stimulation in individuals with Lennox-Gastaut. It takes a community. You've heard that a lot. You'll see the centers involved. We have 6 clinical centers. I will finish with a slide that shows you where you might send individuals that you think would be interested in participating. And also Dr. Erin Warren from the Melbourne group is participating at Beth Israel. And we have a group of brain modelers at University of Florida. These are my disclosures, and I don't need to tell anybody here anything, but I will mention that when you're working with FDA, there's different groups. There's the pharma group, and they're very familiar with Lennox-Gastaut, and then there's the device group, and they are not. Because they haven't dealt with studies with Lennox-Gastaut. So Tracy, thank you so much for coming with us, and Greg Holmes, and we had others that came to really tell them about this disorder, which they really didn't understand that there was such a pressing need. And what we proposed was that we apply what we have been learning about neuromodulation to this disorder using a responsive neurostimulator. The responsive neurostimulator, the RNS system, contains the neurostimulator itself that is placed within the skull and attached to leads. The leads contain electrodes, and the basic concept was to place those leads in regions of interest and to have the neurostimulator watch all the time and respond when patterns of significance are seen with brief pulses of electrical stimulation. In addition, the neurostimulator collects data, and that data is transmitted to a secure database. We call it the Patient Data Management System, which contains the totality of that patient's experience. And that includes every time a detection of abnormal activity has been made, what type of abnormal activity has occurred, and then also provides samples of the intracranial EEG. This is, what we call a window to the brain, and it truly is. Just an example of how the device is placed, the neurostimulator is placed in a full thickness craniotomy. It is the same thickness and curvature of the skull underneath the scalp, can't be seen. And the leads are located wherever makes sense. And the physician can interact with the device with a programmer, but the patient, in this case family, also have a remote monitor. They're able to pull information from the neurostimulator and then transmit that to the physician so that the physician can review data from any internet accessible location and follow what is going on with his or her patient. So here's the basic concept. It's kind of like a cardiac defibrillator, but way more complicated. The intent is that the device will watch the brain signals all of the time, When something happens that is of concern and that has been identified by the physician as important, it will make a detection automatically and provide a stimulation. The stimulation is also determined by the healthcare provider, and then the device looks to see whether there has been a favorable response. And in this way, it is constantly in the background doing neuromodulation, not waiting for a seizure to occur, but it's kind of like throwing a, if you throw a match in dry brush, you stamp that out before a fire can occur. This is the type of data that is seen. Here's examples from the device of a seizure. This is a seizure in a patient participating in the clinical trials of focal onset seizures. And down below you see count data. And what this is showing is the numbers of detections that the device has made over time. And so this is a way to also monitor how the treatment is working, not just the RNS system treatment, but perhaps the addition of a new medication or changes in sleep-wake cycles. But this kind of assessing how a patient is doing in real time without relying entirely on seizure counts is very powerful. Now, the device was initially developed for persons with focal onset seizures, doing the standard process that is needed to get an FDA-approved indication for use. And that begins with a feasibility study, the intent showing that the device is safe and that there's some reason to believe that it's efficacious. And based on that, one is given approval to conduct a randomized controlled trial. And then with device studies, there is always very long-term follow-up mandated by FDA. So there is, in patients with focal epilepsy, 9 to 14 years of ongoing prospective data. So you get a very good sense of the response over the long term. Now the head you see is an example of where leads were placed in the focal onset epilepsy study. And the point here is that there's a great deal of experience using responsive neuromodulation every place in the brain, and understanding that it is safe, it's well tolerated, and that this approach can be effective. The effectiveness illustrated here. This is, again, patients with focal onset seizures, and there's a couple of points I want to make. The light blue is what happened during the course of the clinical trial when we were just learning how to do this. We did not know really what should be detected. We did not know really how to provide stimulation. And fortunately, there was a very nice response early on, but over the 9 years, you'll see that that response continued to improve. This is something that is true of neuromodulation, which is different than drugs. Neuromodulation has a different mechanism of action on networks that takes longer to express, so our trials have to be designed differently. But we also learned a lot in this study, and in the orange, you'll see the more contemporary experience, where there is still this improvement over time, but the bar is much higher. And this shows the effect of learning from the data. Based on what we have seen from the RNS system, our approach to detection and to stimulation has evolved. Well, we have several publications that have come out about applying this technology to persons with Lennox-Gastaut syndrome. And one of the targets that has always been of interest is the central median nucleus of the thalamus. That's a thalamic nucleus that has very broad connectivity to the frontal and the parietal lobes, which is an area where we see many of the EEG abnormalities in patients with Lennox-Gastaut. Our device was used off-label into children with Lennox-Gastaut who were treated in the central median nucleus responsively, meaning that they weren't provided stimulation all the time. They were provided stimulation only when abnormal activity was detected. The first observation here that was so profound is that we could detect seizures in the thalamus. Nobody knew that before. And what we found is that the device, using our standard detection algorithms, absolutely can see when a seizure is beginning in the thalamus and intervene before the individual experiences a clinically evident seizure. And you'll see in this very early experience the results were quite strong. But of course, the most important study, which you have heard mentioned today, is I don't know if, I'll have to ask Dr. Aaron Warner, who is here and who's working on our study, if it's pronounced Estelle or Estelle. But this was applying DBS on a schedule, a duty cycle. 20% of the time the patient was receiving stimulation to the central median nucleus to the thalamus. And not data obtained from this system, but definitely in this small study, a reduction in patient-reported seizures. It did not meet statistical significance, but one wouldn't expect that in such a small study. This has only taken 6 years of development to be at a place where we are now enrolling in this study. And thanks to the NIMDS, as I mentioned, who has funded this close to $10 million to do this study. So here it is. This is, as an epileptologist, the heartbreaking disorder. It's the one that just makes you sick. And I want to make sure that we do this the right way. So this is a feasibility study to understand how to treat Lennox-Gastaut syndrome with responsive neurostimulation. And depending on what this study shows, we may or may not be in a place where it makes sense to go ahead with a full pivotal study to lead to an indication for use. The intent of this is to show, to demonstrate safety, to show effectiveness, and also to, as I mentioned, learn how to apply a very powerful and flexible technology. It is a study that will have a baseline, 2-month retrospective, 1-month prospective, and in order to provide stimulation to the network, which we believe is the central median nucleus and this region of the frontal lobe that Dr. Warren and his colleagues have defined, we will be placing 2 neurostimulators in order to have 4 leads. There will be 20 patients. We do not know the best way to provide stimulation. In our focal epilepsy patients, it has been very short bursts of very high frequency. There is some literature to suggest that longer bursts of lower frequency may be effective. And so individuals participating in the study, it'll be a crossover design during which one condition is sham stimulation, one is high frequency, short, and the other is low frequency, long. And based on that, we hope to understand the best approach. The key inclusion criteria you see listed here, I am very happy to share them with anybody, but NIH has, FDA has allowed us to go to 12. NIH felt uncomfortable with that and said 15 for the first group. Hopefully we will be able to move the age down to 12. You've heard a lot today that if you wait too long, it may be too hard. These are individuals, of course, who have failed to respond to anti-epileptic drugs, and I would imagine in most cases to VNS. We need to know that they have Lennox-Gastaut, so many of these criteria are to be certain that we have a confident diagnosis. Now, this is a scientific study also, and we, as I mentioned, want to learn everything we possibly can, and one of those is the best place to put the leads. And so that in also determining best stimulation settings. But we also are going to continue to follow individuals to continue to refine detection and stimulation. This is something that can be modified over time. And we want to create a prototype of a truly closed loop system using biomarkers and AI techniques that we've been spending the last couple of years developing internally. The first patients are being enrolled, and I just wanted to share this with you. And this is Dr. Aaron Warren and also Chris Butson at University of Florida have been tremendously helpful. But each of these individuals is undergoing network modeling using diffusion tensor imaging and fMRI, and our understanding of our electrodes and how our electrodes behave when provided certain stimulation settings. We are defining the network. And in this individual, you see the central median nucleus in the yellow circle, and the extension of that to the frontal region. In our first patient, we found that this network which we usually define by anatomy textbooks, is not the same on the right as on the left. And so we've heard a lot about the heterogeneity of Lennox-Gastaut, and I think we're going to find that the networks involved in these seizures are not the same in each individual, and so the ability to tailor precisely to that individual may end up being very important. So here is the modeling in our patient, and based on this, we decided exactly where to put the individual electrode contacts by defining that nucleus, CM, in the thalamus. It's a very small target, and then also using our understanding of how that network extended, placing cortical leads there. And the data that we're getting is extraordinary. And it is very clear that this is a process that is involving a region and not a spot. So if any of you have patients or know of individuals who would be interested in discussing more about this study, these are the centers that are participating and enrolling patients. We have 6 centers, and we would love to continue to provide information and also to offer the opportunity to participate in this study for those who are so motivated. Thank you. Yeah, right. So, our colleague from LivaNova, I mentioned all neuromodulation devices get better over time, DBS, VNS, and the question was, how do you account for that effect, the variable of time? And that's the difficulty with device trials. You can't do a 12-week study like you can with medications. It doesn't work. So by doing this, we're actually going to be tracking the biomarkers as well, and the periods of time in each arm vary depending on the clinical response and the biomarkers. So if patients have to return towards their seizure baseline during the sham period before they transition into the next treatment. And we're also randomizing when the various therapy approaches are being offered so that we can then calculate what effect time may have contributed to effectiveness. Yeah, the trial design is very important, and I think unfortunately we've probably lost a lot of effective therapies by not also necessarily defining the best outcome. And so we've heard several people say that you've got to figure out what seizures you're counting. And in our study, we're counting drop seizures or events that would have led to a drop. Don't care whether it's generalized tonic-clonic, tonic, or atonic. For the primary endpoint, it'll be the drop. Because I think that having a narrower definition has been a problem with some of our studies.